Thanks very much. I'd like to use this half hour or so to talk about improving TB outcomes using host-directed therapies in tuberculosis. And I'm going to use the first few slides to talk about what I think should be described as a hidden post-TB pandemic. I think all of us are aware that case fatality rates for pulmonary tuberculosis have declined progressively since the advent of anti-TB chemotherapy some 60 or so years ago. And as a result, the number of TB survivors continues to grow. Since 2000 alone, it's been estimated that there are something like 54 million persons who have survived TB globally. And despite this enormous number, knowledge of post-TB health outcomes really has slowly accumulated over this time. The first clue that something was amiss came early, and that is that there is permanent loss of FEV1 in most TB patients. And I've shown here an example from 1988. I think it's one of the nicest papers by Paul Wilcox. So what is FEV1? It's the ability to inhale fully and to exhale rapidly. It can be expressed as a volume in terms of liters of air, or as a percentage of the predicted value based on the patient's age, sex, race, and height. And here what Wilcox did was call back 70 or so TB patients cured up to 16 years after they completed chemotherapy. And this is 100% would be the predicted, their predicted value for FEV1. And as you can see, particularly in patients who had moderate or far advanced disease based on their baseline x-rays, substantially reduced FEV1s. Clinically important values begin to appear at about 70 or 60% of predicted FEV1. The second clue, I think, is one that we are coming to realize more slowly, and that is that all-cause mortality is increased about threefold post-TB. This figure here comes from a meta-analysis by Romanowski in Lancet ID. This is now from about 2 years ago, 10 or 12 studies in total. If the value had been 1, there would have been equal survival in TB patients and in controls, and there's not. And the risk is pretty consistent across all of these trials. This here is described as a standardized mortality ratio, or SMR. This adjusts for age and sex in looking at mortality risk. Can also be described as shortened longevity. And there's one study of a US cohort that analyzed it this way and found about 4 years shortened life expectancy. Only a small number of studies have looked at the cause of death, and it seems to be mainly pulmonary and cardiovascular. Pulmonary, mainly pneumonias, and cardiovascular, mainly infarctions, heart attacks. Interesting that MIs should turn up here. We do know that bacterial pneumonia increases the risk of myocardial infarction. It should not be terribly surprising that tuberculosis does as well, but this is really new territory. Well, what else do we know about this? Well, FEV1 turns out to be a very strong predictor of long-term mortality risk. And this relationship holds true even in persons without recognized lung disease. And it's most evident in low-income countries where TB is most prevalent. And this study, published a couple of years ago in Lancet Global Health, followed something like 100,000 people globally for 7 or 8 years and looked at mortality risk in relation to baseline FEV1. And as you can see, the risks climb, particularly in the low-income countries where TB is most prevalent. And what's particularly striking here is that the magnitude of the post-TB mortality increase is consistent with what you would expect from loss of FEV1. This is, I think, beginning to pull together these bits of a puzzle that we have been ignoring. And the last clue is that the magnitude of the global post-TB health burden, this is in terms of DALYs, or disability-adjusted life years, is nearly equal to that we currently recognize as being directly due to TB. This study is by Nick Menzies. It's in press in Lancet Global Health. And this is an interesting way of representing the magnitude of this problem. The horizontal axis here is years of life, and the vertical axis indicates the level of disability. So if you're up at the top, you're not disabled at all, and if you're down at the bottom, you're no longer living. And this area in yellow is healthy years of life. The parts in green are what we currently think of when we think of tuberculosis. So people are ill at the time when they have active TB. This is the green area here. And some people do not survive to the end of treatment. This reduction in years of life in green here. The blue area is new, and this is disability, lifelong, post-TB, and shortened life expectancy post-TB. And the key thing here is that these blue areas are about equal in size to the green areas. So when we think about tuberculosis, we are currently addressing only about half of the TB problem. So our hypothesis in thinking about host-directed therapies is that we can improve long-term post-TB outcomes by promoting the recovery of lung function. And in essence, patients may come in over here in terms of FEV1, and if we can improve their outcomes so that by the end of treatment or a year or so after they are here instead, we can expect to see an improvement in mortality risk. That's the concept. Is it feasible? We think so. I think most of this audience may have read the paper that we published earlier this year in Lancet Respiratory Medicine, a study in which 2 of 4 experimental adjunctive treatments improved lung function at the end of treatment. End of TB treatment. The experimental treatments were given for 4 months. And the 2 that were of greatest interest were CC-11050, a phosphodiesterase inhibitor, and everolimus, an mTOR inhibitor. And they both yielded durable increases in FEV1, about 6% when measured 6 months after TB treatment had started. It seems likely that these could recover 2 of the 4 years of life lost post-TB. But it was surprising, actually, that we found these 2 medicines, very different mechanisms of action, that had very similar effects. And the apparent involvement of multiple pathogenic mechanisms seems that it might offer opportunities for alternative interventions and possibly tailored interventions based on particular pathogenic mechanisms in particular patients. Some patients have more fibrosis, some patients have bronchiectasis, and we wondered if these interventions could be differentially helpful to specific groups of patients. So what I'd like to spend the rest of this time on in this talk is specifically to go into the question of reactive oxygen species in TB and protection of the lung from oxidative damage. So Reactive oxygen species are produced abundantly by MTB-infected cells. Under some circumstances, they can kill intracellular pathogens, so it's not necessarily a bad thing, but they also clearly can damage cellular proteins and cause cell death. Glutathione, shown here, or abbreviated GSH, can protect cells and tissues against oxidative damage. The reaction is shown here, 2 glutathione molecules, 1 free oxygen radical. The result is the glutathione is oxidized and dimerized, and the end result is water. This is a simple reaction, but it consumes glutathione, which quickly becomes depleted in preclinical models and in TB patients. The answer to this problem seems most likely to be a molecule called N-acetylcysteine, or NAC. Cysteine, an amino acid, a sulfur-containing amino acid, is required for glutathione synthesis. It's conditionally essential in that its de novo synthesis is insufficient to meet needs during periods of sustained or intense inflammation. We could get additional cysteine in the diet. In most omnivore diets, there's a modest amount of it. It's mainly in meat and eggs. It's rather lacking in vegetarian and vegan diets. NAC, shown here, the central portion of this glutathione molecule, is a temperature-stable, orally bioavailable form of cysteine that's been in use clinically for about 5 decades to reduce sputum viscosity. You may be familiar with NAC as part of the routine to process sputum for TB culture, to prevent COPD exacerbations, and to prevent death due to acetaminophen or paracetamol-induced hepatic toxicity. And this is probably its largest use worldwide. When administered orally, NAC undergoes rapid metabolism and conversion to glutathione. As one study now from about 30 years ago looked at the plasma concentrations of N-acetylcysteine after oral doses of 200, 600, and 1200 milligrams. The concentrations here are normalized as to dose, and as you can see, the increases are in exposure are greater than what you would expect if it was just proportional. And this apparently indicates saturation of the metabolic enzyme or enzymes that result in the conversion to glutathione. NAC can be given orally or intravenously. Oral dosing of 3 grams twice a day, the highest dose I could find in any publication, seems to be adequately tolerated. Patients in this study had AIDS and tolerated this dose for several months. IV dosing is used more often for Tylenol poisoning because patients are often ill and may be vomiting for other reasons. So oral or IV in these studies. There are a large number of publications looking at both preclinical and clinical effects of NAC. In vitro, it prevents necrosis of MTB-infected cells, so shown here as LDH release from infected macrophages, control cells, and NAC-treated cells. And here showing necrosis in lungs and in spleen of MTB-infected guinea pigs. There are some studies showing direct antimicrobial activity in vitro, and some showing antimicrobial effects in the lungs of TB-infected mice. I'm not sure how relevant these are to this current project because the doses and concentrations that were used in these studies may not be achievable clinically. In any case, a large number of studies have looked at the clinical effects of NAC in COPD. The 600 milligram twice a day dose prevents COPD exacerbations. Lower doses do not. And one study looked at this dose in TB patients and found that it protected against TB drug-induced liver injury. And also multiple studies looking at doses in the range of 3 grams over several days, repeatedly over several days, prevents death due to massive hepatic necrosis after acetaminophen poisoning. And then one recent study looking at TB drug-induced liver injury found that this hastened hospital discharge, a study recently in South Africa. So our study, NAC-TB, participants were adults providing written informed consent, first episodes of pulmonary tuberculosis, sputum expert confirming infection and showing a relatively heavy burden of infection, and a chest X-ray showing moderate or far advanced disease. Patients were randomly assigned to either standard TB treatment or that plus NAC 1,200 milligrams twice daily for the first 4 months. The dose is sufficient to increase sustained oral intake by about 5-fold compared to an ordinary diet. And patients who were HIV infected either continued ART or started it during the period of study participation. We looked at lung function at baseline at 2 weeks, 2 months, and 6 months, looked at sputum at intervals by liquid and solid culture, and measured oxidized and total glutathione. So total glutathione being the sum of GSH and oxidized GSH. They were measured in whole blood samples using a colorimetric assay from Arbor assays. We chose whole blood because glutathione levels in cells are much higher than those in plasma, and we hypothesized that those in blood cells, levels in blood cells would be similar to levels in other cells in the body. We calculated a reduced or a biologically active glutathione as the difference between these two measured values. So the total glutathione minus oxidized. What I will show you will be the results of an interim analysis, the first 93 patients with spirometry data at month 6. 30 additional subjects have not yet reached month 6, and we should have data on these additional patients within the next few months. At baseline, the patients were relatively young, thin, had a relatively heavy sputum burden of infection, and were mostly male. And about half had far advanced disease, and about a quarter were HIV positive. The arms were reasonably balanced, although 43 patients, so nearly half, were recruited at the start of the study, entered the study under pre-2019 ATS-ERS guidelines, and that those limited the use of spirometry in patients either with acute pulmonary infections or with tachycardia, which is common in TB patients. The now revised guidelines remove these restrictions. And that's the reason for recruiting these additional 30 subjects to better understand the baseline parameters. We found NAC to be well tolerated. There were no attributable discontinuations or deaths due to adverse events or lack of tolerability. GSH was low at baseline. These values here are about 1/4 of those reported in healthy Europeans. We are still doing a survey to establish the normal range for TB patients in Tanzania, which is where this study was performed. It did not differ among the arms, nor did it differ according to HIV status. We show here the change in glutathione from baseline over the course of the study. In black are shown the control subjects, in red, the NAC arm, and the circles show the total glutathione, and the triangles show the free or biologically active glutathione. The levels remained rather constant in the controls, increasing a small amount over baseline during the entire period of observation. Whereas in the NAC recipients, they increased substantially. The levels of total glutathione rose quickly by 2 weeks, and the levels of free glutathione rose significantly by 2 months. The levels continued to rise in the NAC recipients through the period of NAC administration, and then fell to levels similar to the control arm after NAC was stopped. The spirometry data are shown here in this slide. This is shown as histograms at month 6. Each dot here represents an individual subject, and these curves are smoothed histograms. Overall, there was a trend toward improved FEV1 in the NAC arm, about a 6% improvement that did not quite reach statistical significance. But the surprising observation was particularly in patients with severe loss of FEV1, that is less than 50% of control. And these here are significantly fewer in the NAC arm than in the control arm. There was no effect on forced vital capacity, and no effect on the, and then a significant effect on the FEV1 to FVC ratio, which was improved in the NAC arm. We found no effect on the hazard ratio for sputum culture conversion. The two curves tracked very closely throughout the entire period of treatment. So in conclusion, adjunctive NAC treatment restored glutathione concentrations in the blood of TB patients and appeared to promote the recovery of lung function. The finding was not due to effects on sputum viscosity, as it persisted for 2 months after NAC treatment had ended. And specifically, we found that NAC reduced the proportion of patients with severe FEV1 impairment and increased the FEV1 to FVC ratio. So this is consistent specifically with amelioration of bronchiectasis. It did not affect the extent to which you could inhale, but it did improve your ability to exhale rapidly. And that's what you would see with an effect on bronchiectasis. Adjunctive treatment with NAC may reduce post-TB disability and promote longevity after TB cure based on its effects on FEV1. I'd like to thank everyone who for their help in this study, particularly people at the National Institute for Medical Research, Mbeya Medical Research Center, Issa Sabi, Juliet Lalasholi, Nyanda Nintinginya, and Daniel Mapamba. Daniel did all of the GSH measurements and all of the sputum cultures. And a team that included many people from LMU, from Orem Institute, and not the least of which the funding from the German Ministry for Education and Research. Thank you very much, and I'll take any questions.